Hello. Yes, we can start.
So, good morning, everyone. Today, we'll be discussing a case of atypical optic neuritis. So, a 7-year-old female resident of Khanapur visited ophthalmology OPD with complaints of sudden painless loss of vision in both eyes since one day. On examination, her uncorrected visual acuity was found to be finger counting at 1 meter in the right eye, whereas it was found to be finger counting at 3 meters in the left eye, which was not improving. On examination, there was RAPD present in the right eye, whereas a sluggish pupillary reaction was noted in the left eye. Fundus examination showed disc edema, bilateral disc edema. This is the fundus picture of the patient at the time of presentation. We can clearly see there is a disc edema present bilaterally. The patient was started on oral steroids and was referred to a neurologist, was also advised a series of serological blood tests and MRI. On follow-up visit, the uncorrected visual acuity of the patient was found to be 6 by 18 in the right eye, which improved to 6 by 9, whereas it was 6 by 24 in the left eye, which improved to 6 by 12. The pupillary reactions were as present earlier, that is RAPD in the right eye and sluggish reaction in the left eye. The fundus in picture showed disc edema with mid-peripheral vitreoretina interface changes bilaterally. This is the fundus image of the patient on follow-up. That is, this was taken 1 week after her initial presentation. We can see the edema has reduced. So based on these clinical pictures, clinical features, and the history, a few differentials that come to our mind are as follows. So let us try to rule out them one by one. So coming to papilloedema, papilloedema is generally optic disc edema which results due to raised intracranial pressure. However, in early stages, the optic nerve function, the visual acuity, and color vision is usually normal, and the pupillary responses are also normal. Also, the patient comes with symptoms of raised intracranial pressure, such as transient obscuration of vision, the headaches which are present before waking or on bending forward, and there may be associated nausea and vomiting, which is a projectile type of vomiting. The true optic nerve head edema also shows the following features, that is hyperemia, microvascular abnormalities like telangiectasias or flame-shaped hemorrhages on the optic nerve head surface, and there is opacification of the peripapillary RNFL. Since the visual acuity and color vision generally remain normal in papilloedema and the pupillary responses are not affected, we can rule out, and the other signs of raised intracranial pressure are not present, we can rule out papilloedema. However, an MRI is to be done for diagnostic purpose. Coming to the second differential, that is pseudopapillitis. It is generally seen in optic disc drusen, congenital optic disc anomalies, myelinated nerve fiber, or peripapillary masses like astrocytic hematomas. It can be unilateral or bilateral. However, the visual acuity, color vision, and pupillary responses are not affected. So this is a picture which is showing an optic disc drusen. The first image, which is showing an optic disc drusen. The second is showing a papilloedema. We can clearly see there is disc edema and opacification of the peripapillary RNFL. The third shows a surface drusen, and in the fourth image, we can see the astrocytic hematoma. So now, since both the differentials have been ruled out, the third differential, that was optic neuritis, let us discuss briefly about optic neuritis. So it is an inflammatory disease of optic nerve leading to decreased visual acuity. It is associated with demyelinating disease, and it can be grouped under typical and atypical optic neuritis. It is classified as retrobulbar neuritis, papillitis, and neuroretinitis. In retrobulbar neuritis, the optic disc is normal as the optic nerve head is not involved. It is generally seen in adult demyelinating disorders, and is associated mainly with multiple sclerosis. Papillitis, there is optic disc edema along with a few peripapillary hemorrhages. And in neuroretinitis, there is presence of papillitis along with inflammation of the retinal nerve fiber layer. The etiology of optic neuritis, it can be idiopathic or associated with demyelinating disorders like multiple sclerosis, Devick's disease, Schilder's disease. It can be para-infectious, that is post-viral infection or a post-immunization. Non-infectious in systemic inflammatory diseases like sarcoidosis, SLEs, polyarthritis nodosa, or infectious, that is cat scratch disease, syphilis, herpes zoster. So, as I said, the optic neuritis can be grouped into typical and atypical. So, the typical optic neuritis is generally present with multiple sclerosis, which is a idiopathic demyelinating disease involving the central nervous system white matter. It is generally seen in more commonly seen in Caucasian women. The presentation is typically in third to fourth decades with a relapsing remitting demyelination. Around 20% of MS patients have optic neuritis as their first presentation, and about 70% of MS patients will develop optic neuritis somewhere during the course of their disease. Presence of oligoclonal bands in CSF and MRI brain showing periventricular demyelinating plaques in the white matter is generally a feature of multiple sclerosis. Clinical features, there is decreased visual acuity. The color vision loss is more than the vision loss, more profound than the vision loss. RAPD is present in uniocular involvement or asymmetric in bilateral involvement. The two phenomena, that is the Uthoff's phenomena, which is worsening of visual function with heat or exercise due to defect induced in the electrical channels during impulse transmission, and Pulfrich phenomena, that is a 2D image is perceived as a 3D image due to unequal signal transmission time as a result of demyelination or loss of myelin sheath, are typically seen in typical optic neuritis. So anything that is a deviation from the typical presentation of optic neuritis and associated with diseases other than multiple sclerosis comes under the category of atypical optic neuritis. So this is a chart, which table which is showing the different differentiating features between typical and atypical optic neuritis. As we can see, where typical optic neuritis is unilateral, atypical generally presents bilaterally. Typical optic neuritis presents in the second to fifth decade. Atypical is present in the extremes of age, that is either in very young or very old patients. Typical is associated with pain, whereas atypical is generally painless. Vision loss peaks at 2 weeks, following which recovery occurs in typical. However, if there is a progression of vision loss beyond 2 weeks, the clinician should suspect for atypical optic neuritis. The response to treatment is very good in case of typical optic neuritis, whereas atypical is resistant to treatment and requires prolonged treatment. Disc edema may or may not be seen in typical, whereas atypical generally the disc edema is present. Multiple sclerosis is mostly seen in typical optic neuritis, whereas other diseases other than multiple sclerosis are present in atypical optic neuritis. So the most common autoimmune causes for atypical optic neuritis are antibody-mediated disorders like neuromyelitis optica, a spectrum disorder, myelin oligodendrocyte glycoprotein antibody-associated disease, and chronic relapsing inflammatory optic neuritis. So we'll discuss them one by one. Starting with anti-myelin oligodendrocyte glycoprotein syndrome. The myelin oligodendrocyte glycoprotein is expressed on the surface of oligodendrocytes and myelin in the CNS. It is a major cause of pediatric and adult demyelination. A high prevalence of anti-MOJ antibody positivity is seen in patients of prion, and equal preponderance of males and females is seen. Often these patients are diagnosed as demyelinating optic neuritis, and the diagnosis of anti-MOJ antibody is considered only when the steroids are tapered as per the optic neuritis treatment trial protocol and a rapid relapse occurs. So these are the clinical features. Anti-MOJ antibody is more commonly presents bilaterally and involves the optic nerve head, resulting in optic nerve head swelling. The response to pulse steroid is excellent. The classical feature, the optic nerve MRI, generally shows involvement of the long segments, but does not involve the chiasma. And also there is a perineural enhancement. The relapse rate is high, especially after rapid taper of steroids. However, CNS symptoms and relapse of CNS symptoms is less commonly seen in anti-MOJ antibody positive patients. Diagnosis. The MOGAD is diagnosed on the basis of the latest proposed criterion published in January 2023 in the journal Lancet Neurology. The proposed criteria require all three of the following. That is a core clinical demyelinating event, positivity for MOG antibody, and exclusion of a better explanation, including MS. So this is a chart which is showing the various diagnostic criteria which are required for diagnosis of MOGAD. All criteria, that is A, B, and C, need to be fulfilled to be diagnosed as a case of MOGAD. Starting with core clinical demyelinating event, it can be either optic neuritis, myelitis, ADEM, that is acute disseminated encephalomyelitis. Then positive MOG IgG test. If it is a clear positive test, no additional supporting features are required. However, if it is low positive or positive without reported titer, or it is negative but positive in CSF, then aquaporin 4 IgG seronegativity and more than one supporting clinical or MRI feature is required. The supporting clinical or MRI features include optic neuritis. It has to be bilateral. More than 50% length of the optic nerve has to be involved. The perineural optic sheath has to be enhanced, and optic disc edema should be present. In myelitis, it is longitudinally extensive myelitis, central cord lesion, and a conus lesion. The brain brainstem or cerebral syndrome, multiple hyperintense lesions in the supratentorial and infratentorial white matter, deep gray matter involvement, and the pons, middle cerebral peduncle or medulla should be involved. And the last criteria is exclusion of a better diagnosis, including multiple sclerosis. So we have to fulfill both all three A, B, and C criteria. Coming to the treatment part, there are no published guidelines for the treatment of MOGAD. So, if it is a first clinical event, the various tests are blood tests and MRI and other clinical and paraclinical features will help you in the diagnosis of MOGAD. And for acute treatment, we give IV methylprednisolone 1 gram for 5 to 7 days. If there is a lack of response to IV therapy, we can go for plasma exchange. After acute treatment, maintenance therapy or preventive treatment, we start with if there are poor prognostic factors, that is presence of persistent MOG antibody positivity. If it is present, then we start the patient on oral steroids plus oral immunosuppressants or IVIG. And if the patient is showing lack of response, then we can go to monoclonal antibodies. However, if poor prognostic factors are absent, we can start the patient only on oral steroids for prolonged tapering until cessation. And after you stop the oral steroids, you keep the patient under close monitoring to check for any evidence of relapse or recurrence, after which we can again start the patient on oral steroids and immunosuppressant therapy. The next antibody-mediated atypical optic neuritis is NMO-SD, that is neuromyelitis optica spectrum disorder. It is against aquaporin 4 water channel, which is present at the foot process of astrocytes. The NMO antibodies attack the water channel aquaporin-rich regions, that is the hypothalamus, optic chiasma, area postrema, and brainstem involvement. The clinical features, there is pain on eye movement, bilateral loss of vision, profound visual field defect, dyschromatopsia. Other neurological features, which are generally associated because of the transverse myelitis, is decreased coordination, paraplegia, sensory impairment, bladder or bowel impairment, respiratory failure. Due to hypothalamus involvement, there is symptomatic narcolepsy. Nausea and vomiting is generally seen due to area postrema involvement. Intractable hiccups, nystagmus, internuclear ophthalmoplegia is present due to brainstem involvement. So if a case of optic neuritis, if a patient with optic neuritis comes to you and any of the following symptoms that were just discussed is present, we can order for a anti-aquaporin aquaporin 4 IgG antibody test. The NMOSD is diagnosed on the basis of international consensus diagnostic criteria published in July 2015 in the journal American Academy of Neurology. So it can be with aquaporin P4 IgG, that is if we are testing for that, and the other is without the aquaporin P4 IgG status. So with the aquaporin 4 IgG status, at least one core clinical characteristic has to be present, a positive test for aquaporin 4 IgG, and exclusion of alternate diagnosis should be present. Without aquaporin 4 IgG or with unknown status, at least two core clinical characteristics which meet the following criteria. That is, one should be either optic neuritis or acute myelitis. Two or more different core clinical characteristics should be present. Fulfillment of additional MRI requirements and exclusion of an alternative diagnosis should be present. So this is a table which is showing the various criteria. We can see the core clinical characteristics include optic neuritis, myelitis, area postrema syndrome, acute brainstem syndrome, or symptomatic narcolepsy. On imaging, there is a normal appearing brain MRI, normal in the sense that no lesions specific to multiple sclerosis are present. Optic nerve MRI shows enhancing lesion which is extending more than half optic nerve length and involves the optic chiasma. Area postrema lesions, lesions in the dorsal medulla or area postrema. Acute brainstem syndrome, periappendymal lesions are seen, and a spinal MRI which shows cord enlargement and cavitation, and at least three contiguous vertebral segments have to be involved. CSF shows decreased serum CSF albumin ratio, normal IgE synthesis, and most important is absence of oligoclonal bands, which are a pathognomic feature of multiple sclerosis. Serology, seropositivity for aquaporin 4 IgG autoantibodies. This is an algorithm for treatment of neuromyelitis optica. If it is a first episode or if it is a relapse, we start the patient on urgent IV methylprednisolone. If there is a poor response, we can go for prompt plasma exchange. After the acute treatment, we start the patient on prolonged oral steroids plus immunosuppressants like azathioprine, methotrexate. Following which, if there is relapse on adequate doses for more than 4 months, we can start on monoclonal antibodies like rituximab. Alternative second-line immunotherapies like cyclosporin, cyclophosphamide, and regular IVIG and plasma exchange can be considered. In 2019-2020, the US FDA approved 3 monoclonal antibodies for seropositive NMOSD, including eculizumab, which is an anti-complement protein C5, inebilizumab, B-cell depleting anti-CD19 antibody, and cetralizumab, an anti-interleukin 6 antibody. This is a table which is showing the differentiating features between a anti-MOG antibody positive optic neuritis and an aquaporin 4 antibody positive. We can see that the optic neuritis is bilateral in MOG positive, whereas it is unilateral in aquaporin 4 positive. Response to steroid is excellent in case of MOG, whereas it is poorly or often resistant to steroid in case of aquaporin 4 antibody positivity. Optic nerve MRI, the MOG antibody will not involve the chiasma, whereas the aquaporin 4 involves the chiasma, optic chiasma. And the relapse rate is high in case of anti-MOG antibody. This is a diagrammatic representation of showing the various areas of the optic nerve, spinal cord, and brain involved in NMO, MOG, and multiple sclerosis. As you can see in the first picture, the NMO, the long segments of the optic nerve and the optic chiasma and optic tracts are involved. Whereas in case of MOG, the optic chiasma is not involved. Also, the perineural sheath of the optic nerve is enhanced. And it is bilateral in NMO and MOG, whereas in multiple sclerosis, unilateral but short segments of the optic nerve, not involving the optic nerve head, are involved. Coming to the spinal cord, the NMO generally is affects the cervicothoracic vertebrae, and the lesion is central, and the lesion is generally present centrally and involves a little peripheral parts also. Whereas in MOG, the medullary conus and the lumbosacral spinal cord is affected. In multiple sclerosis, generally diffuse lesions in the cervical spinal cord is affected, and the dorsal and the lateral horns are affected. In the brain, the NMO affects the periventricular as well as circumventricular areas. MOG, it is generally affecting the brainstem areas, the basal ganglia. And multiple sclerosis, it affects the periventricular white matter. It affects the periventricular white matter, and it is ovoid in appearance. The distribution of the plaques along the corpus callosum generally are known as Dawson's finger. Then the third, that is the chronic inflammatory optic neuritis. It is highly steroid sensitive, but also highly steroid dependent. Can be seen in any age group. Generally shows a female preponderance. Visual loss is severe and painful. The disease presents similarly to atypical optic neuritis. It is a diagnosis of exclusion. The diagnostic criteria generally includes there is a recurrent optic neuritis, seronegativity for aquaporin 4 and MOG, rapid response to steroids, but however, there is relapse on withdrawal of steroids. Acute attacks may be treated with IV steroids, while intermediate management may require use of steroids and immunosuppressants and plasmapheresis. Another type of optic neuritis, another type of condition which is generally confused with optic neuritis is Lieber-Stillek neuroretinitis. It is an infectious or immune-mediated process. Up to 50% of the patients have antecedent viral illness, generally affecting the respiratory tract. It generally affects the children and young adults. Associated with cat scratch disease, syphilis, Lyme's disease, toxoplasmosis, and can be seen post-vaccination. The fundus picture is typical, that is optic disc swelling of mild to severe nature, and macular star and exudates are deposited within the Henle's layer, giving a typical star or hemistar appearance to the macula. This is a picture which is showing a 23-year-old man with a 2-day history of blurred vision on the right. We can see that the optic nerve head is elevated and hyperemic with obscuration of the nerve fiber layer. And 5 weeks after the onset, the ophthalmoscopic examination shows a macular star. The presence of macular star may be, the macular star can be seen at the time of presentation or subsequent follow-ups. And the macular star is generally complete. So now coming back to our case, the 7-year-old was advised various tests, blood tests and CSF analysis and MRI brain. So on the CSF analysis, we can see that the oligocolonal bands are negative. Also on the MRI, we can see there is no acute demyelinating plaques. So we can very well rule out the cause of optic neuritis to be typical or multiple sclerosis because of absence of oligoclonal band and no acute demyelinating plaques. So we are left with atypical optic neuritis. Now coming to atypical optic neuritis, as seen from this MRI orbit, we find the findings in the favor of acute bilateral optic neuritis. However, if you can clearly see that both optic nerve intraorbital, intracranial and prechiasmatic segments are involved. So if it is prechiasmatic, we know that NMO involves the chiasma and MOG does not involve the chiasma. So we can hint towards a anti-MOG positive antibody disease. And finally, the serology for the patient showed a negative report for NMO antibody, whereas it was positive for MOG antibody. So the final diagnosis for this patient is both eyes atypical optic both eyes anti-MOG positive antibody associated disease by both eyes typical optic neuritis due to MOG AD. Thank you. These are my references.
What is the indication for doing blood test for antibodies in case of optic neuritis, where you suspect there is a, suppose a patient comes with suspected retrobulbar optic neuritis, when do you go for blood test?
Uh, so we can start, if it is a retrobulbar optic neuritis, we start the patient generally on steroid therapy. However, if there is no response, then we can consider, after 3 days of IVIG therapy, if there is no response, we can consider going for blood test to check for any atypical optic neuritis.
Okay. How do you differentiate between optic neuritis and papilledema?
So like I said, papilledema generally is because of raised intracranial pressure. So MRI will show any signs of intracranial masses which are responsible for the raised, which are responsible for papilloedema. However, such kind of lesions will not be present on in case of optic neuritis. Also, the preceding symptoms of raised intracranial pressure, like I said, nausea, vomiting, is present in papilloedema, but not seen more commonly in optic neuritis.
So what are the signs? How do you differentiate in OPD that this is papilledema and not optic neuritis?
Pupillary signs are normal, sir, in case of papilloedema. The RAPD is generally not present. And color vision also is not affected.
So color
Vision,
vision, everything you have to check.
yes.
Also, fields can be done to check the visual field defect. So what is the field defect seen in case of papilledema?
Enlarged blind spot is seen in case of papillary edema, whereas central or centroschical scotoma may be seen in optic neuritis.
Yeah. So first you have to rule out or confirm by clinical examination, and later you do investigations. Okay. So we do not generally do MRI in all cases of retrobulbar or optic neuritis cases. So we have to rule out that it is optic neuritis and not papilledema.
Yes,
Okay.
yes,
And
yes.
how do you differentiate between papillitis and optic neuritis?
Neuritis and uh, so papillitis is type of optic neuritis.
Yes. So what is the difference? What do you see different from you have shown, I think, in the initial slides?
Sir, papillitis is associated with disc edema, whereas optic neuritis generally is the optic nerve head appears normal.
Okay, that's a retrobulbar optic neuritis.
Yes, that's retrobulbar.
Okay, any other questions by others? Okay, good presentation. If there are no questions, then we